Hi there. So today we're going to look at the shoulder girdle. Get my screen share going here. Have some links here and pictures. I'm going to talk about jelly real quick. This is a little acronym that we have to tell which way the arm is positioned, internal versus external. So the greater tubercle is seen on the external rotation, so palm up in anatomical position, and the lesser tubercle is seen on the internal rotation, medial. So that's kind of our acronym. Here's our greater, letter A, on the outside when the thumb is out and external rotation. When you turn your hand internally, here's where the greater sometimes is seen. I don't really see it in this picture, but the little bump of the lesser moves in. Over here is our lesser here. So when you turn your hand in, that moves medially, and there's like a little bump of it seen in the little glenoid cavity almost here, or in profile medially is how the book words it. Some more pictures of some radiographs. We have external rotation, internal, and neutral rotation. Have some Quizlet diagrams for you. Some questions and discussion board things that we could do. Just ask yourself if you can answer these questions. That will help you on exams. And I have my presentation for the shoulder girdle that you can look through. Pictures from the book. Here's our video of the shoulder.
Hey guys, today about the shoulder radiography. I'm going to do two main views that every department's going to do, the AP and the lateral. One is an internal rotation, one is an external rotation. 40-inch SID, 10x12, crosswise or landscape is the preferred way, so you get more clavicle on there. Centered 1 inch inferior to coracoid process. Patient's going to be erect against the wall bucky. Ensure the patient is not leaning. This is probably the most common way and the preferred way. The AP, the line between both of the condyles, is going to be parallel to the IR. That lets you have an AP elbow, which gives you the external rotation. Externally rotate the hand until that line is straight with the IR. That's our AP view. Lateral, the line between the epicondyles should be perpendicular to the IR. We're going to internally rotate the hand until it's touching the back of the hip. And that is our lateral view, or the internal rotation is more commonly referred to in the AP external rotation with the hand out and the condyles parallel. Breathing instructions is suspended. That means you're going to stop breathing in, out, doesn't matter, inspiration, expiration. Just tell your patient, hold your breath, don't breathe, don't move, and expose. Take the picture. Clinical indications: fractures, dislocations, calcium deposits in the muscles or tendons, or bursal structures. Degenerative processes such as osteoporosis and osteoarthritis can also be seen. So here's our video of the internal and external. She has it in crosswise, she's married. Then you're gonna just put your patient in there to center them, get the right height, that 1 inch inferior coracoid process. Gives you about a 2 inch above the shoulder top. So you have to put your marker up there. Once you're married, do not move it. And then position the hand externally till the epicondyles are parallel to the IR. That's our external rotation. Expose, hold your breath, don't breathe, don't move, expose. Switch out your IR. Internally rotate the hand until it's touching the back of the hip. And that is our internal rotated. Still 1 inch below coracoid. I'd bring her over just a slight bit maybe, but that's pretty good. Everything's centered. You have all around the shoulder on there. Room for your marker above. And that's our two easy AP views, internal, external, AP lateral. Here is our external rotation x-ray. You're going to see, if you can look at this and tell it's a external rotation, you're going to see the greater tubercle on the lateral portion. So this little bump of bone, this is our greater tubercle poking out. This is our little intertubercle groove, the space between the greater tubercle and the lesser tubercle, this little groove there. So here's our lesser tubercle. It sits most the anterior surface of our shoulder here on the humerus. So the lesser tubercle kind of sits in the middle. Greater tubercle is out in profile. And that's how we can tell it's an external rotation. We're also going to see the space here, the glenoid fossa, but look, it's touching the Humeral head is touching over the scapula here. This is our body of our scapula outlined. So we can't really see inside that joint. So we're going to do a special view. We're going to talk about that on our live and in the lab. Internal versus external. Here we have both of our views that we just talked about, the internal and external rotation. So here's our greater tubercle on the external. There's the lesser. Everybody's going to be a little different. This is a little different than the last view. Here it is on the bony anatomy. Lesser tubercle here, greater tubercle out towards the lateral side. Now let's look what happens on internal. The internal, the greater tubercle moves into the middle, the lesser tubercle moves medial and is sticking out on its side in profile, so like a profile shot. So here we have the shoulder looks more smooth. Here's a little bump, the lesser tubercle. This line inside here, greater tubercle. So that's how you can tell the difference. Somebody in my x-ray class when I was in x-ray school called the external with the bump and the internal looks like a scoop of ice cream. So if that works for you, the smoother one being the internal one. We also have a little saying for this that we'll talk about in our lives. There's two more extra alternative views that we're going to do in the lab. We're going to practice the Y view, which is also in a video here, and we're going to practice the gray sheet, which is going to be shown in the lab. I don't have a video for that. That is where we're going to look in the joint. The Y view is going to be used for dislocated shoulders. So let's look at the video of the Y view and I'll talk about it. So with this, it's called a scapular Y. The shoulder is touching the board that's hurt. We are turning them to get the scapula on its side or laterally. In the x-ray, it's going to look like a Y. I will show you how to position the right amount of obliquity. It's going to vary on each patient. So you get that scapula straight on, looking down. The humerus stays down. The head of the humerus forms the stick of the Y. Then there's the acromion and coracoid area of the scapula that's going to look like the V part of the Y on the x-ray. So we're just going to center straight through the middle of the body of the scapula and come out through the head of the humerus. And that's what it looks like. So here's our acromion, the back part of the scapula. And you can kind of see this part over here coming up, not the clavicle, but the coracoid process over here. That's the V part of the Y. Oh, here it is. Sorry, I was tracing the wrong bone. And the scapula, this corner here angle, and the humerus coming down. So they kind of move the humerus a little bit out of the body. It should be laying straight over the scapula. This is off of wiki radiography. Usually they are good x-rays, but this one looks more like not for the shoulder, but for the scapula picture. So I think we just might need to fix that. We'll look at it in our book and talk about it more. We're going to have a shoulder dislocation seen in this. Here's the head of the humerus. It should be right in the middle between that V part of the acromion and the coracoid process. If it's dislocated, it's going to either fall towards the ribs, which is to the front anteriorly, or it's going to fall back here in the space under the acromion, which is a posterior dislocation. So this is the only view that's going to give the doctors which way do they need to push that shoulder or that humerus to go back up into the space where it needs to be if it's dislocated. So a scapular Y view is pretty common. Ratio view is another alternative we'll talk about tomorrow and in our lab. So I'm going to stop the screen share. And that's it for now.
All right, guys. So yeah, that picture that we were just looking at was the Y view for the position for the lateral
At Kaiser
scapula.
University, I feel like I'm on the path to success.
It's funny, a Kaiser commercial came up there. Let's see. I'm gonna see if I can find it real quick for you. All right, here's the Y view with the arm down. So you don't have that humerus poking out in the front like we did on that radiograph a minute ago. We still have the acromion, and then over here the coracoid. Wow, this is a really light x-ray. But the head of the humerus is sitting right here in the V part of the Y, and then the scapula is overlapping the humerus, the shaft of it. And then when you have either like this one, it looks like they're a little rotated. You can see the actual curve of the shape of the inside of the scapula, so they're not straight perpendicular to the IR. So that's a rotated one. There's another one that looks rotated. So we'll look at those on image analysis day. But that is the actual proper way here to do our humerus, but we don't have the arm out of the way. And then if you look on this one, you can see the head of the humerus and the arm coming across the body. So they've held it across their body on this one. So we have what we call the scapula Y view, and we also have some that we're going to do for the actual scapula called the scapula. And it's the same position, but it's a lateral scapula. Let's stop the sharing for a minute and just say all of these links are here to help you, and save as much information as what you feel is helpful, and make note cards from it. Do whatever you need to do to remember all the important information for shoulder. So we have the two views, AP views, which are internal, external rotation. We have the Y view, which is a specialty view, and then we have the gray sheet view, which is another specialty view, and we'll have a separate video for that with some other specialty views later on.